with that, I'd like to introduce Stephanie Marquesano, who, by the way, is my counterpart in New York on the State of New York Opioid Settlement Committee. And Stephanie, before I turn it over to you, I just wanted to acknowledge the hard work that is being done in the state of Michigan by several teams. One is led by Michelle Boudreau, and I think Michelle is with the Michigan Department of Health and Human Services. She heads up a team at the state level, and then several of our PIHPs have their own co-occurring disorders teams. And I just wanted to acknowledge that they've been at this for quite a long time and are working hard to implement the stuff that Stephanie's going to talk about and that Dr. Minkoff is going to talk about. So Stephanie Marquesano.
Thank you so much, Mario, and thank you for having me. Thank you, everybody in Michigan. Thank you, Dr. Minkoff, who I always love working with. So I think that probably the best way to kind of tee up this conversation is to go on a little bit of a journey, which is the journey that started at my kitchen table on October 23rd, 2013, the day that my 19-year-old son, Harris, died by accidental overdose. When a 19-year-old dies in a small suburb of New York City, everybody wants to know where they can make donations and what they could do and how they could support our family. My daughter was a senior in high school. We're an intact family. My husband and I were just trying to make sense of what had happened. And in the chaos of my household, it was clear to me that every program Harris had been in said he had this thing called co-occurring disorders, yet somehow within a year and a half of entering the first program, my son was dead. And so for me, the goal was to figure out what went wrong and figure out the kind of things that needed to be done to make change. So I start every presentation, which I do, in schools and communities all over New York State and now more nationally. I bring Harris right into the space by sharing, who he was. Harris was a creative, loving, kind, humorous, athletic, caring, and empathetic kid. Twinkle in his eyes, smile that would light up the room. Every single one of you knows a young person like Harris. For him, all the energy and excitement in the cafeteria surrounded him, laughing and throwing things and getting in trouble. But what you didn't know about Harris, unless you knew him really well, was a lot of that energy and excitement was the only way that he could cope with how he was feeling on the inside. Often we think about young people who are struggling with their mental health as kind of not being super social. Harris, on the other hand, was in the middle of the energy. He took all of his thoughts and feelings that some people push in and he projected them out. So on one hand, his energy kind of guided his sometimes poor decision-making. But on the other side, he was one of those people that was very intuitive. He knew when his friends were struggling. He knew when to offer a hand or an ear. And so here we are 9 years later, an amazing son, brother, relative, and friend who is really missed by so many people. We went through his friends graduating from college, and now a lot of his friends are getting engaged and married. And for my family, we can still feel obviously that gaping hole in the fabric of our family and his friend group where he's missing. So for those of you who don't know, I like to share sort of a baseline understanding of what co-occurring disorders is, which is a diagnosis of one or more mental health challenges and substance misuse, drug and/or alcohol. Research suggests that more than 70%, and it's really well more than 70% of all of those misusing and addicted to substances have co-occurring disorders. That's more than 10.2 million people in this country alone who meet the criteria for a diagnosis. And when I started the Harris Project, literally, Harris died on Wednesday and his funeral was on Sunday. Between Wednesday and Sunday, I created the Harris Project, the only nonprofit in the nation committed to co-occurring disorders. 9 years later, we are still the only nonprofit that sits squarely in this space. Our goals are simple: raising awareness and transforming the national perception and management of co-occurring disorders, enhancing treatment options, prevention programming, support, and that line through research. I will say that there are a large number of people that are really interested in that piece, and that's really the piece where Dr. Minkoff entered my life. So I look forward to sharing a little bit about that. We advocate for early mental health screenings, diagnosis, and referrals to provide appropriate treatment. Prevalence data is really overwhelming, especially since so many people have never heard of co-occurring disorders. 22% of our youth 13 to 18 have a mental health disorder in a given year with severe impact. That means between 1 in 4 and 1 in 5 of our young people are truly walking around not feeling comfortable in their own skin. For Harris, he felt very alone with his struggles. He didn't realize how many other young people were feeling kind of the same way that he was. 50% of all lifetime mental health disorders begin by the age of 14, 75% by the age of 24. That matters because between 14 and 24 is when a lot of young people and a lot of just parents in society believe that experimentation is a rite of passage, not really understanding the relationship. Almost half of youth 8 to 15 with a mental health disorder don't get any services at all, which would be like saying, somebody has a peanut allergy and we say, you don't need to carry an EpiPen or go see someone until you have that anaphylactic reaction. Or somebody tears their ACL and you say, you just walk around on it until you really can't move, and then we'll worry about seeing an orthopedic surgeon. With mental health, we tend to wait until our young people are in crisis. And that is something that we really work to empower communities on, is how to get help and support at the earliest possible moment. And then once our young people are in treatment, very few get services for more than 3 months. So what does that mean? That means that by the time our young people get navigated to services, 43% have in the mental health side have a co-occurring substance use disorder, 70% on the substance use side have a co-occurring mental health disorder. We also don't silo causes of death around here. So we talk about overdose and alcohol-related deaths and completed suicide, and more often than not, even when we collect data around those, we keep them in separate buckets. Same is true on the adult side. 1 in 5 adults have a mental health disorder in a given year with severe impact. That's more than 10.2 million people having co-occurring disorders, and we know not enough people are getting the mental health support that they need. We're not talking about anything fancy. So by way of backgrounds, I should share, I'm an attorney by training. I'm not a mental health provider, not a substance use provider. My lens is one of lived experience, but these are all things that anybody could find. We're talking about things like depression and bipolar disorder, anxiety disorders, PTSD, obsessive compulsive disorder, ADHD, and oppositional defiance disorder. I always share pieces of Harris's story because I think that there are lessons to be learned in each step of our experience. He was diagnosed with this when he was little with an anxiety disorder, and as an early teen with ADHD. We were seeing professionals throughout his life. Not one ever said to us or to him, Harris, good-looking, popular social kid like you, such extreme anxiety, you better be really careful around substances because that could be a rabbit hole that you're going to go down really, really quickly. Very smart kid, very involved family. That would have been the first step for things to be different. Instead, he stopped playing sports when he was in middle school. I was on the school board. Harris was in 8th grade. His behavior started becoming what my husband and I would call unpredictable. We thought he was losing his mind. Everyone in our community thought Harris is just trying to get away with stuff because you're on the school board. I ended up resigning. We ended up pulling him out of school and homeschooling him for the end of 8th grade. At the very last session, which would become the very last session with the therapist he was seeing, he said, so Harris has become more than I could manage. And by the way, I think, he's been smoking marijuana. I thought he was just experimenting, but I think that he could have a problem. So when I do this presentation for young people, this is the time where I tell them that just because they think that there's no risk associated with marijuana because it grows and it's natural, how important it is for them to do their own research and education around this. If you look up boys, anxiety, marijuana, and psychosis, that was going on in my household. We didn't know that that was even a possibility. When it comes to marijuana use in the developing brain, there really is no such thing as experimentation. And yet, once again, as a nation, and I'm here in New York State where we legalized for commercialization last year, we never think about what we need to do upfront regarding prevention and those dollars. So Harris was self-medicating with marijuana. He really wanted to go to our high school and we switched therapists and he was evaluated and he picked up the ADHD diagnosis, went on medication for the first time and started doing really well. so well that he stopped seeing the therapist. He's like, I don't need to see the therapist. Medication is working. If you or people you know and love are on medication for a mental health disorder, so important to maintain touch time with a therapist, because if anything comes up, thoughts change, medication doesn't work, you need a place to put that. Instead, 11th grade came, stress and pressure, ACTs, SATs, am I playing college soccer? Anxiety overwhelmed the medication, went to a party in my town, prescription pills were available. That's when I could say the game was over for us. Within a year and a half before he died, 1 short-term mental health inpatient, 2 substance use outpatient, 4 substance use inpatient. Once he entered the substance use rehabilitation programming, that was the end of anything to do with mental health, even if they promised that they would deliver co-occurring capable care. So how do you get it? For most people, they have an existing or an emerging mental health disorder. They're using substances to self-medicate, not to party, but to be able to go to the party feeling comfortable in their own skin. Some people have that true co-occurring mental health and substance use disorder, those things happening together. And then imagine 1,000 young people in an assembly, they're thinking, this is kind of interesting, never really heard of this, but at least she's not talking about me, like I don't have a mental health disorder. But this final category is one that impacts all of our young people. So your brain not being fully developed until you're 25 means vaping, marijuana, nicotine, alcohol, misusing medication. All of those can lead to brain changes that can lead to the development of a mental health disorder, even if you weren't on track to. I do a lot of programming with student athletes, both at the high school and the collegiate level. Student athlete gets injured, they're legally prescribed opioids. Do they know they can become addicted or dependent in 5 days or less? Do they know that there might be depression that comes along with the break-in routine? These are the kind of consumer education messaging that is missing and is clearly important. Then we talk about the impact of genetics, family history, and trauma. How do we break these generational, intergenerational challenges, repeating history? Well, if a family member struggles with alcohol use and has depression, and the young person has depression, it's important for them to know that they can break that cycle by getting help and support that their older family member might not have even known would ever exist. So these are how we make those systemic changes, because even today, much of traditional rehabilitation programs mean walking through the door, taking away the substances, even the ones prescribed for a mental health disorder, being placed in a group, not really getting face time with a mental health professional. Harris used to say to us, they keep saying, remember life before substances. I love my family, I love my friends, I love my house, I love my car. My brain works 1,000,000 miles an hour. If I don't get any real tools when I leave here, how does this not happen again? And so we often hear about people going through that revolving door, and some people subscribe to the philosophy, you have to reach bottom or you have to want it badly enough. No, we really need evidence-based treatment taking place in these programs to best meet the needs of the individual. A lot of blaming and shaming and, calling people addicts. And again, if you're somebody in recovery, if you're somebody who's using substances and that's how you refer to yourself, that's fine. But with our young people, we really look at person-first language, strength-based conversations, and thinking about what it means to be told over and over again when you're a teenager in a program that that's all you are. And so we never knew what to do yet. Next, recurrence and use was always inevitable. And then, I'm an equal opportunity, I throw everybody on the bus kind of person. So on the flip side, many mental health providers, once you share that you're using substances, will say, you need to go take care of that first, sequential treatment. When you're done with the substance stuff, give yourself a couple of months, okay, and then come see me. Not evidence-based. Then you have some that'll say, well, I can't deal with your substance use, so you're going to go here for your mental health and there for your substance use. That's what happened with Harris. The first time he came out of a residential program, I was taking him to the intensive outpatient program, the 12-step meeting, the psychologist and the psychiatrist, recurrence and use in under 2 weeks, because none of that was evidence-based. He was hearing different messaging from different people. Ditto, psychiatrists, many will not prescribe, which is not evidence-based, while you're still substance involved. I'm going to move past the poem, but I'm going to give it to all of you to, Mario will share this after, because it's kind of like, it grounds me and it is my why for why I do what I do, but I don't want to take away from Dr. Minkoff's time. This slide to me tells a lot of tales. It is the one place where they compile data around alcohol deaths, drug deaths, and suicides. So in 2020, that was 186,763 people. If you think about the numbers that had co-occurring disorders, I will say that co-occurring disorders is the largest public health emergency that most people have never heard of. And when you look at the staggering overdose rates for our adolescents, mostly because of counterfeit pills, nearly doubling in 2020 and rising another 20% in 2021, we know we're in a lot of trouble. And I'm not even going to go into the additional risk factors and problems that have come from emerging from the COVID-19 pandemic and what that's going to do over the long haul on the mental health and wellness of our young people. So this brings me to Dr. Minkoff and my meeting him. So I knew that I wanted to do this thing around co-occurring disorders, and I wasn't quite sure how I was going to get there. I always say that in my tragedy, I'm the luckiest person in the world because the right people have entered my life when they needed to. So for me, that happened in 2016 when I met the commissioner for the Department of Community Mental Health in Westchester County, where I live. We were going to have a roundtable and write a white paper on best treatment practices for co-occurring disorders. We were going to raise a lot of money and write a protocol, and ultimately I was going to open a place called the Harris Project. I got connected to Dr. Minkoff through a person down in Florida who had known my son in a program. And I emailed Dr. Minkoff, and I write the way I speak, and I vomited out my whole dreams and hopes for this. And he emailed me right back, Stephanie, can you call me now? And we got on the phone, and the first thing he said to me was, I've got good news for you, and I've got bad news for you. The good news is you don't have to write the treatment protocol. It's already been written. And he introduced me to SAMHSA Tip 42, the updated cover you see right now on this slide. The bad news is that book was written in 2005. And if people were using it, young people like Harris would still be alive. Now, that was a lot to take in, but I thought, well, okay, I don't have to raise the money to do this, but I need to understand the lawyer in me, like where this has gone wrong. So Ken also said, if you choose to accept this mission, you can transform the system of care for everybody. And ultimately, you can open a place called the Harris Project when you retire. So what went wrong? So let me just say, this book is like 600 pages, and SAMHSA wrote it, and it's got all the right people building out this model. The challenge comes because the federal government writes a protocol, but every state in the United States decides what it does with its mental health and its substance use dollars. And even if they operate underneath the same roof, they are typically siloed agencies. Funding is kept separate and things don't work together. In New York State, our Office of Mental Health gets like $1 billion, and Office of Addiction Services and Supports the same. Now, when I present to kids, that 600-page book really comes down to just the little bit that's on the right side of the slide. Coordinating mental health and addiction professionals to create an integrated, comprehensive treatment plan, meeting the needs of the individual, medication when it's appropriate, positive and supportive social interactions, healthy recreational activities, family involvement, no wrong door. Kids are like, what is wrong with the adults? This doesn't seem all that complicated, yet it seems to be. Our journey, which was very laborious and really a process, started with Dr. Minkoff in 2016 on Harris's birthday, April 8th, Zooming, well, he wasn't Zooming in, it was just a little box in the middle of the table, sharing with us ways that we could begin the work around building a system of care. And then we started having conferences and forums and building our stakeholder community and really motivating people from community organizations, hospitals, providers, people that were committed to this even through an unfunded way. Like, we didn't really know where the dollars were going to come from, and I've gotten grants since then, but we've really worked to build out this system. Advocacy started happening because we were doing such great work. Our legislature wanted us to write a white paper on what we were doing, on what the current barriers were. When we got our opioid settlement dollars, I was there getting the check for our state. We have young people that advocate and testify, and we do all of this great stuff. And because of the New York Times article, which I have a free version of, which I'm happy to share with everybody with no paywall, I spent, at the end of the summer, I was at the White House twice, talking with them about the ways that we can make impact. Opioid settlement law, which impacts the whole country, co-occurring disorders is included throughout. In New York State, we now have a single agency bill, which has passed our Senate 2 years in a row. We think this is going to be the year that the Assembly, with a good sponsor that we now have, will finally finish the deal. We have a bill in to amend our health curriculum in the schools to include co-occurring disorders as a bridge between mental health and substance use. I sit on our New York State Opioid Settlement Fund Advisory Board. As you can tell, I'm not really a shrinking violet. I like to talk about this topic in particular. And the only concern I had when Mario teed up the conversation about the 8 pillars, co-occurring disorders without a real system could technically be an afterthought or just another thing in the pile. In New York State, and I'm happy to share our complete report, which is like 675 pages, but the bulk is pages 10 through 42, don't get scared. We actually have co-occurring disorders as an overarching theme on every single recommendation, meaning prevention, harm reduction, continuum of care, special populations, transportation. Everything is involving a no wrong door framework. Our siloed agencies are working together to create the RFAs that are going out so that every dollar spent, the people applying for funding have to demonstrate a commitment to co-occurring. If we continue to fund what exists right now, we are doomed for failure. And so we are really very forward thinking in our work. Prevention is the happiest place and the place that gets the least attention. Everybody typically worries about overdose and kind of the end. My happy place is the beginning. So we have branded and logoed co-occurring disorders awareness. Our 2-star logo is really designed to empower our young people to think critically about pathways to use, to think about, help-seeking behavior and the kind of things that they can do in their communities to make impact. CODA has been, we're now partnered with Students Against Destructive Decisions. So we're going to be rolling out nationwide through their 8,000 chapters. Again, this was a very bottom up, meaning like the young people were really the motivation and incentive for administrators at the school level to want to get more involved. We work with our Board of Cooperative Education Services. We tell the story behind the stars. We have youth summits and homecomings and awareness games, and we celebrate co-occurring disorders awareness in April, because when you start a nonprofit for a disorder nobody's ever heard of, you pick when you want to celebrate. Harris's birthday was April 8th, and so April has become Co-Occurring Disorders Awareness Month. This is kind of what our hybrid youth summit looked like, 750 students zooming in from 46 of our high schools in Westchester. We have social media campaigns and poster campaigns. And really the bottom line on this, and the one takeaway I'd love you to have, is that early intervention is really the game changer. My hope is, after I present to young people, that they really understand why waiting much longer for first use is really beneficial. Do I expect them all to be abstinent from substances until they're 25? I wish it, probably not likely. So I ask them to think about their why. When you're at that party and you're deciding what to do, why are you doing this? It's kind of like my generation. You go to a cocktail party, you're holding a drink. You go to a ball game, you're holding a beer. We've kind of lost the ability to feel what we feel. And so this is really a way for them to stop and think. We have social emotional learning tools and things that we do to change that. We've also, so I feel like there are so many levels, and Ken's going to go really deep into the systems work. So for us, it's systems, it's prevention, it's looking at how to integrate our state agencies and use our opioid settlement dollars wisely. But one of the missing pieces here was, I now have a young person with co-occurring disorders. They've heard me present. The agency is doing their systems transformation work, but what is the clinician actually offering by way of treatment? So Encompass is an evidence-based treatment protocol developed by Dr. Paula Riggs out of University of Colorado. Samson did not have this book when we first engaged her. We were kind of the guinea pig. She's in a lot of research institutes. We have 6 providers, 40 clinicians, no insurance, underinsured, Medicaid, private insurance, private pay, bilingual clinicians, LGBTQIA+ clinicians, really trauma-informed, doing work that's 16 weeks of outpatient individual sessions, family components when they're, indicated, cognitive behavioral therapy, motivational enhancement therapy, contingency management, really successful model that we've been having great results with. So this is me, my contact information. I hope you'll reach out if you have specific questions for me away from the webinar, and follow us on social media as well. And now I'm going to stop sharing and I'm going to turn it over to Ken.
Before Ken, we're gonna, before Dr. Minkoff starts, Stephanie, there was that one slide that you breezed through and it had different things listed. What was that slide again?
Which topic?
Boy, I can't recall. You know what? Don't worry about it. Okay.
Okay.
The net for everybody participating, both slide presentations are going to be shared through our website, so don't worry about that. And there was someone else in the chat feature that said that she could record it. We are recording it, and we do a little bit of editing. We don't edit out any of the content. We just do a little bit of cleanup, and then we put that on our YouTube channel. So you don't have to take notes. Just sit back, take it in, learn, and know that both presentations are going to be shared with everybody vis-a-vis our website. And I want to say this before Dr. Minkoff starts. In that study from over 20 years ago, Dr. Minkoff said this: comorbidity is so common that dual diagnosis should be expected rather than considered an exception. And boy, now more than ever, we need to be thinking about these things. And with that, I'll turn it over to Dr. Ken Minkoff.
Well, thanks, Mario. And thank you, Stephanie, for, as usual, an amazing, energizing presentation. I'm always honored to be considered a helper to you because you have such fabulous energy and passion and have the capacity to accomplish so much. And I'm very grateful to Mario and FAN or FAN or however you describe yourselves for the opportunity to be here sharing with folks in Michigan. One of the areas of focus is, I don't know who is out there listening of the 45 or so people who are on this call, but I'm guessing that some of you are people that I know and have had interactions with, and some of you are folks who are brand new. As you see, this says Zia Partners. That's me and my wife, Chris Klein, and that's our consulting company. There's just two of us. We're in Tucson, and we're in the changing the world business. And we've been working, we started working in different parts of Michigan about 20 years ago, and worked enough with different PIHPs throughout the state when there were 16 of them. That at about 15 years ago, the state took this process on as a statewide initiative and involved all of the local community entities in developing a systems approach to co-occurring services. And that process really created a lot of positive energy. We worked with creating a change agent group that was there. There was a southern group of several hundred people and a northern group of several hundred people. And there's a continuing state co-occurring disorder work group that brings together local leaders from all of the different communities to work on these issues. And there's been fabulous progress in Michigan in bringing this issue forward. And the consciousness of co-occurring stuff over time has affected a lot of developments in the state, including a lot of the work that you've all done on developing and expand. And this is just the recent things, building out your certified community behavioral health centers across the state, and developing your crisis continuum across the state, and so on. There's a lot of very good things that have happened, but there's a lot more work to do. And the opioid settlement funding and the way in which that funding and the funding board and the decision making have been used in New York to leverage more systemic progress around co-occurring services is something that creates a wonderful opportunity in Michigan as well. And because wherever you're going to find opioids, you're going to find other substances. And wherever you're going to find concerns about opioid use, you're going to find co-occurring mental health conditions, including trauma. And wherever you find mental health and health conditions, you're going to find people with substance use issues and significant risk of opioid use, misuse, overdose, and death. So this is a good time to be looking at all the progress that's been made in the past 15 years and say, let's take this now to the next level, because we have a real opportunity to use a whole new piece of energy and funding to not just create some new programs, but look at how we can actually further change the world in Michigan. And the language of changing the world is what it says. It's about designing the whole system at every level to be about the people and families who have all kinds of complex challenges, who need help the most. And when I'm talking about everything in the system, the driver for doing this are stories like the ones you just heard and the stories that many of you already have. That, you know, whatever you call it, what transformation, integration, recovery-oriented, trauma-informed, there are people coming to the door with all kinds of desperation, encountering systems and structures and rules that make it feel like the job of getting help when you're desperate and complicated is going to be really hard. The people we serve experience this, the people delivering service experience this. And what we've been working on and learning for decades is that we're never going to get where we need to go simply by trying to fund some special programs or hire a few special people to work around what often feels like a dysfunctional system. What we need to be thinking about always is how do we leverage everything we do, every process, meaning if we're thinking crisis services, that's a process. If we're thinking prevention, that's a process. Every program, every policy, procedure, every practice, every person providing help with every penny that we have to be about the needs and hopes of the people that we're serving and the values that brought us all together in the first place. Now, the thing that to start with is we're putting, as Stephanie did so graciously and bravely with her own son and her own family, is putting real people in the middle of our conversation and thinking about who are we talking about? Because we're talking about people who have overlapping issues. Any combination of any mental health issue and any substance issue, whether or not those folks have already been diagnosed, wherever their ages are, wherever their backgrounds are. And these folks show up everywhere. They show up in all kinds of settings. They don't just have mental health and substance issues. They have medical issues, housing issues, legal issues, parenting issues, disability issues, cognitive and learning issues, et cetera. These are folks who are characterized by complexity. And the more complex you are, the worse you're likely to be doing. So these are folks who are having the poorest outcomes and the highest costs in our scarce resource service system. And their poor outcomes are in every conceivable domain, including the fact that they're more likely to cost money all over the place, including in the health system. And they're the folks who are tragically most likely to die. And if our job is to design our system to be about the people who need us, then naturally we would be thinking that people with co-occurring needs would be appropriately prioritized for care everywhere they show up. But yet what we experience, and you guys have been working on this for years, so you've made a lot of progress, but still there are so many times where folks show up and they're experienced as misfits. And those misfit experiences may be at the level of the individual clinician, they may be at the level of program design, but often they're at the level of things that you collectively now, with things like opioid funding, have the power to change, which is state policy, funding instruction, regulation, whether it comes through the state departments of the Department of Community Health, or increasingly through all the managed care intermediaries that are hired by the state to fund all the services that are being delivered, who may have no instructions about how to support co-occurring services at all in their contracts and in the way they do their business. So there's a lot of opportunity to build a lot of what's being learned into more of the architecture of the system, so that we move these folks from misfits, where people often experience like, I'm not sure what to do and you're in the wrong place, to design a system where people with co-occurring conditions and other complex needs are specifically, purposely, and proactively welcomed for help exactly as they are, wherever and whenever they show up. And what we're welcoming people into is the experience of hope. And one of the things that is important to emphasize is that every piece of passion and values has to be the cornerstone of the way we design our bureaucracy. So when the first part of the slide says we have to not only welcome people with co-occurring conditions, we have to inspire people with hope that by virtue of having come in any door, that they are going to be not only welcomed in, but inspired, that they know it's a good idea they've shown up because people care about helping them with all their issues to have a beautiful life. That's not something we just hope people remember to do while they're filling out lots of paperwork. That's actually an expected product of our work, is that wherever people show up, hope is enhanced, not reduced. And that every person, every family, especially those who have the greatest number of challenges, are purposefully inspired when they meet us with hope for having a tremendous life. And those are things that can actually be measured and embedded into the architecture of the system. And that's part of the foundation of the work. Now, the key, as Mario kept saying, is that the driver for doing this in your state, as everywhere, is that not only are these folks with co-occurring issues doing poorly, and when opioids are involved are exceptionally high risk of death, but that there are lots of them. So the prevalence of co-occurringness, as Stephanie so eloquently explained, is so great in every one of these settings that co-occurring is an expectation, not an exception, pretty much everywhere we look. And it's not that we don't know this, we do. What's striking is the degree to which so many parts of the service system are still designed as if this were not true. So the goal, okay, and you guys have been on an adventure for 15 years, but the goal is to constantly be thinking, as Stephanie was pointing out about the opioid fund decision-making in New York. It's not like we set up a special co-occurring program. It's not that we hire some co-occurring clinicians. It's not that we find special co-occurring funding. It's that every funding, every program, every policy, every initiative is designed with the idea that co-occurring people or co-occurring families, and by co-occurring families, I mean little kids who have emotional issues, who have substance using parents, who may be in the child welfare system, that co-occurring families are at the other end, so that we leverage our capacity to help as many people as possible within the resources that we have. So all services are designed this way. All funding is designed to support it. All policies and regulations are designed to create the expectation. All improvement activities are designed to continuously improve services for people with co-occurring needs. So in the framework that we've been using in Michigan, New York, in the regional project that Stephanie described, and all over the world, it's got this little piece of jargon to it. But the basic message is the same. Every program becomes a co-occurring program that's welcoming, hopeful, strength-based, all this good stuff. And every person providing help is a co-occurring helper. And every program may have a different job, and programs tend to be supported by lots of different funding streams. But whatever they're funded to do and whatever their job is, they should be designed with the expectation that the next person coming in the door has co-occurring needs. And within what they do, whether they're a psych unit, a residential substance program, an outpatient clinic, mental health case management, school-based outreach, whatever they're doing, they should be designed to be delivering co-occurring care. Similarly, every person providing help. This is not just people having 2 degrees. It's whether you have 1 degree, 2 degrees, 3 degrees, or none. You're a peer support person. You're working the overnight shift in the residential substance program where all the clients are trading psych meds and acting strange. Everybody needs specific instructions to know how to be helpful and hopeful to the people with co-occurring needs that are already sitting right in front of them. And this needs to be built into everything from basic training to how you design your competency expectations once people take the job. So this is there's a lot to do, and I call it a recovery process for systems. And it's an organizational process, not an individual process. It means that each component of the system has to own its own improvement activity, step by step over time, to continuously improve its ability to do within its span of control, whether it's delivering services or funding services or regulating services, or just an individual trying to be helpful. Everybody has the power to continuously improve what they do and move in the direction of the system that the people we're serving need and want. Now, there are tools to help folks do this. Some of these tools have been being used in Michigan for some time. I don't know the extent to which the use of the tools is, continuously supported as part of the QI system, and people are regularly doing their improvement activities. There are also newer tools that have been developed since we stopped working with Michigan. So one of the tools is on there is what's called the Compass Exec, which is if you're someone who's running a PIHP or a CMH or a state agency, and you want to sit and look not at what services you deliver directly, because that's not what the focus is. You're looking at how you run the system. How are you managing the care in the system? Your oversight processes, contracting processes, quality improvement, utilization management, funding instructions. You want to look at all that and see whether you're supporting integrated care. You use the Compass Exec. You want to do that for children's services, and not only do it in behavioral health, but bring in juvenile justice, education, and intellectual disability supports. You use the SOCAT tool. And then there are program tools for different types of programs, and every program gets its own 12 steps, and there's stuff for staff and so forth and so on. Now, the key to this is that, as I was pointing out to Stephanie, and she was picking up on, and her kids were picking up on it even more. When we look at the research and you get past the idea that the only answer is to create a special program, but instead you want to design your services to be about helping people. What we learned, and this is a project I did for SAMHSA in the 90s, is that you can look at the research and say, what is it that inside all the programs that have been researched, what do they do that actually helps people in those programs? And how can we take what's been learned and embed them not just in special programs, but in any program, so that any cool group of people trying to be helpful to the folks with co-occurring needs they're already serving have very specific things that they can do to be helpful. So the program actually becomes a co-occurring program within its mission and resources. And when you dig into this, it turns out that it's actually pretty simple. And over the years, the 30 years that I've been doing this, the main thing we've learned is to keep making it simpler. And the biggest problem is that everybody has a tremendous time doing the simple things that work inside their span of control. And what gets in everyone's way is that we get so complicated in our heads and we find so many ways to get confused and we have so much jargon and gobbledygook that it makes it very hard for us to do simple things. So if you're a funder and I say, and you say to me, oh, well, I can't fund co-occurring services unless I can blend funding streams. I'm going to say, well, what funding, if you have in your mental health funding stream, what instructions do you give people about delivering integrated services to people with mental health who have co-occurring substance use? And they say, I can do that? Yes. Is that allowed? Yes. Well, how do I do that? Well, it's pretty simple. I can write it for you in about 15 minutes if you want to implement it. And the same thing for someone who's got substance funding, how to give instructions for co-occurring mental health. In fact, right now, the American Society of Addiction Medicine, which develops patient placement criteria, is working on their 4th edition of the criteria for substance services. And they're really hardwiring co-occurring capability into everything much more strongly than they did previously. I'm on the co-occurring writing group. This is going to come out in 2023. And it's really going to have a stronger impact on instructing everybody about what to do with substance funding and substance funding programs. And the same thing needs to happen at mental health. Okay, so there are 6 basic principles that can be turned into instructions for program design, staff competencies, funding instructions, regulations, so that everything becomes co-occurring. Okay, and there's a quality improvement processes using tools and step-by-step measurement and inspired change agents. And you saw Stephanie's great picture of change agents that help everybody to come into this. But the key is what I call the serenity prayer. The serenity to accept the things you cannot change, the courage to change the thing, which is everybody else, the courage to change the things you can, your own work, your own team, your own span of control, and the wisdom to know the difference wherever you are, whether it's your own work, your own program, your own pot of regulations inside the state system, the way you oversee intermediate funders like managed care organizations. Everybody has some piece of capacity to move the needle forward. And there are 6 simple principles. Co-occurring is an expectation. Incorporate that into welcoming practice, customer service in everything we do. Get very good at welcoming the opportunity to identify co-occurring issues, both clinically and in our data systems, so we see the co-occurring people that are there. Once people are identified, we don't refer them, as Stephanie described, to 6 different places. We connect them where we are into an integrated partnership that is empathic, hopeful, integrated, and strength-based, where we can work with people in small steps over time on all their issues to help them achieve their vision of a successful life. We recognize all co-occurring issues are not the same. There are more severe issues, less severe issues. Different programs have different jobs. In any community, each program should get good at its job and help other programs with their job. All the issues are primary. The best practice for anybody is to get the best intervention for each issue at the same time, in the same place, in small steps, including medication and non-medication interventions for both conditions. We move with people through their stages of change for each issue, because people may not be in the same stage for each issue, and interventions for each issue need to be stage matched. And then when we make change, our job is not to just tell people what to do, but literally teach them the practical skills for how to do it. Self-management skills, asking for help skills, medication skills, non-medication skills, in very small steps, with lots of practice and lots of rounds of applause. This is not rocket science, but it's very hard to get us to put these instructions into all aspects of the service system so that everybody is building what they do, whether it's in primary care, mental health care, substance care, around the expectation of co-occurringness in each and every person and family that comes in the door. So this is what we want to create in the system, where everybody shows up and receives welcoming, empathic, hopeful, ongoing, integrated support partnerships, where they get help for multiple issues with adequately supported community-based learning for each issue, so that people and families can achieve the goal of having happy, hopeful, meaningful lives, which they're all capable of achieving and deserve to get. And they certainly don't deserve to unnecessarily die. So thank you, and I look forward to questions.
Okay, there are a few questions, but I wanted to ask a few questions. First, Stephanie, the name of the clinician in Colorado who was instrumental in writing some of the language. Did you mention her name or his name?
So Ken, do you want to unshare so this way we can all see each other?
Yeah, sure.
So, so the Encompass evidence-based treatment model is out of the University of Colorado, and it's Dr. Paula Riggs, and it's been very successful with teens and transitional age youth. Paula didn't develop the modalities used. It's a combination of cognitive behavioral therapy, motivational enhancement therapy, and contingency management. All evidence-based protocols, when put together, seem to have very good results dealing with co-occurring. So it's not really a special program for those special people, but it's an easy to deliver modality so that, one of the questions in the chat was about, staying in one's lane. If you provide those who are the most adverse to change and to really learning about the other, a way to deliver things that's seamless, effective, and doesn't take more out of their time and energy, and it's successful, it's been a really good opportunity for them. Because I think that's part of the other the beauty of working in a 7-county region where there's such a commitment to the work, and working with Dr. Minkoff, is we have work groups around developing core competencies, what kind of framework we need so that every person working in every single agency, from the receptionist all the way through to the CEO, really understands what it means to deliver co-occurring services, how you speak to people, how you welcome them warmly, how you're not handing them off someplace else. You're expecting them to come full of complexities. What we do is we take our most complicated people and we make it hardest for them to get the help that they need. And so this is the kind of moment to say, we're good, you're here, we're happy to have you, and we're going to be able to keep you here and do the work. I would rather for Harris to have stayed in a place with good people who may not have been able to do everything quite perfectly, rather than to go someplace that was like dividing him, splitting him, and making him feel really like it was his fault.
Yeah, so let me add on to that, because Stephanie, you're reading my mind. I wanted to pick up on that, stay in your lane. Who decides what the lane is that people have? If you say, oh, you're a substance person, that means you've never talked to people about their mental health issues. Is that the right lane as a substance professional? I mean, you shouldn't behave as if you are a mental health expert therapist, but you should be talking to people about their mental health issues, because if you're trying to help them with their substances, their mental health issues are going to be right there. And if we don't teach you even to know as much as a layperson about a mental illness, and to help people with substances, to help them manage it and feel like they can talk with you about it, so you can help them develop better skills to succeed, even help them know how to take their medication properly and support it, then that's not helping you be a successful substance professional. We need to define the lane so that people feel like they know what to do and it fits their ability. Conversely, as a mental health professional, you should know how to be asking people about substance use and talking to them about it, and asking them about what their choices and decisions and concerns are, just like you would around any other piece of behavior in their lives.
Yeah.
And if you're partnering with them around, what's going on, you can help them and guide them in making better decisions and choices. And if they're struggling with addiction, you can help support them in what they're doing. That would be the proper lane for a mental health professional. And so the fact that we imply that people should have a lane, and in the lane you can only do one thing, sets up our clients to have a more complicated life and to feel like very few people can help them. And if co-occurring were super rare, then it would make sense that we hire a few special people. But you're a mental health professional, you're going to be seeing people with substance use and vice versa. So this is something everybody should just know how to do. This is part of the lane. So, and we figured it out. I mean, it's all written what the competencies should be and how everybody can acquire them. And you don't have to, and when you do it, you're having a lot more fun. This is much better for you as a clinician because you're actually being more helpful and enjoying yourself instead of struggling. But that's exactly the point I was making, is we have to go to the next level of detail and really help every aspect of this be in the co-occurring business.
And so the answer to Jermaine's question is there are no lanes. You learn.
No, that is wrong.
Okay, what is
Sorry, Mario.
No,
I hate to
I want
bite
to
the hand that
understand.
invited me. No, there are lanes. The lane should include co-occurring competency.
Correct.
Okay. In other words, if I'm running a program, I want my staff, I know that whatever the program is, they're going to be working with co-occurring people. Every person I hire, I want them to understand within their job and level of training what their co-occurring lane looks like, because they all need a co-occurring lane.
Okay.
I need them to know what they're supposed to do to be helpful. Okay. I can also tell them what they're not supposed to do. Like, you're a social worker, don't prescribe medication. Okay. Okay. But as a social worker, I want you to be talking to people about multiple issues. You don't have to be a substance expert to be inquiring about substance use and welcoming people's opportunity to talk to you about it. And somebody asks you something and you don't know what to do, ask somebody for help.
That's
But
one
you
thing.
should be in those conversations. Absolutely.
Go ahead.
We do a lot of
Stephanie.
that, Mary. We do a lot of, because we have both mental health under the OMH license and substance use under the OASIS license, providers at the table together, they learn and grow and work together. They push in to help and provide support. But one of my favorite analogies that Dr. Minkoff puts out that I use all the time when you're building that system and that framework is that if everybody in your agency left tomorrow and new people all came in, would they know what your philosophy was? Do they know what's in the manual as far as building that co-occurring system? Because what often happens is you get some really good people at the table, they start making progress, things are happening, and then the director leaves and this one leaves, and it's not it's not like put into the guidelines.
Institutionalized. Exactly right.
And so that is a really important thing to create life beyond. So Dr. Minkoff travels everywhere and kind of plants these seeds and they grow. I'm here in Westchester working in the Mid-Hudson region, but as far as bandwidth goes, you want there to be life beyond what you're doing in this moment. And so I think that's part of, I think that Michigan has done some really great work. Dr. Minkoff and I presented at an American Psychiatric Association conference, and there were some people there from Michigan, and they were trying to figure out like where the drift happened and how things happened. And that's because if you're not kind of like documenting and chartering and really like building that long-term opportunity, you kind of miss out. And I think that's kind of where.
That's right. Because people love to get excited and get trained. Everybody gets trained, and you have like Michigan has co-occurring college. It's a lot of fun. Great people come there and they learn a lot. But ultimately, to anchor the change into your system, you have to challenge yourself to answer every one of these questions. If somebody says, well, I don't know what to do with our funding streams, then you say, well, why don't we get help? Because somebody knows how to give you the right funding instructions. Somebody knows how to give you the right licensing instructions, the right regulation instructions, the right program design. how to run a co-occurring group and how to have all your groups in an addiction program be co-occurring groups, to define competencies for each type of staff person. The work has been done. Okay, if you ask me to rewrite a piece of your regulation, I can probably do it in 15 minutes because I've done it so many times. But I can't change your regulation for you. I don't have that authority. So you have to decide, we're going to do this. If we don't know how, it's okay. But it's been done. Ask somebody for help and they'll help you. And then you can put it into play in your organization. So it's done and done properly, because you can do it wrong and make it worse. So rewriting your policies is really important, and using opioid settlement funding to give resources for capacity building is really important. Okay, because it looks like a lot of money and you think, oh, we can do all these cool things with it. But it's a small amount of money compared to the total amount of money being spent on behavioral health in Michigan.
Yeah.
And if you use your funding to say, okay, what do you need to build co-occurring stuff into all your rules and policies and oversight functions and all the things that hold our system in place and make it easier for people to be successful? What kind of resources would help you do that? And we're going to make some of these opioid settlement resources available to support our PIHPs and our MCOs and the places where there's a lot of money being managed. That's going to be fabulous.
We include our Department of Health in the work as well, because we have overdose prevention centers and we're looking at different ways to kind of address the harm reduction space. But the one gap that they noticed was the lack of mental health services. And so they're a player at the table as well.
So I was going to ask the question about how to best fund integrated services and, spend the opioid settlement funds that are coming into Michigan, but you just answered that question, Dr. Minkoff, when you just talked. So I'm not going to ask that question. Are there places in the United States that are doing this, metaphorically speaking, rounding third base, or, they're just off to the races? Yeah. They've changed their legislation, the guideline, they're getting it done at a benchmark level.
Well, the legislation, I mean, it's variable. There are places that have changed some things and so on. So we did some work some years ago, and I want to answer the question about hiring helpful and hopeful, because it's a very good question in the chat. So I'll run into that too. But
yeah,
we did some work with the state of South Dakota about 10 years ago, plus or minus. And during that period, we didn't change their legislation, but they were able to reorganize the state system and change essentially all of their administrative rules. The nice thing about working with a state like South Dakota is that their rule book in South Dakota is probably 1/10 of the size of that in Michigan and 100th of the size of that in New York. And as far as we can tell, having a much bigger rule book does not make your services any better. Certainly having a smaller rule book makes it much easier to change it so it works well. So they were able to do that. I don't know where they're at now because I haven't talked to them in 5-6 years. But that was a great piece of work. There's a project going on in Milwaukee that they've been working for the last 15 years, almost 15 years, where they have about 1,000 change agents working steadily on improving services with in the county system, in the community-based county system. So that's really infused things up with a tremendous amount of energy from peers and families. There's something in San Diego called the co-occurring cadre that has been training itself and working on improving the policy and practice in the county for 20 years. And, in each of those places, those are county level stuff that runs up against what happens at the state. So it's very variable. You know, there are places of strength and there are places of limitation all around. And what I think is important for Michigan is I'm trying to keep the message simple. You've done a lot of good work. As states go, you have one of the best architectures for creating change in the co-occurring committee, and the way that there's some capacity for doing this built into each of the local systems. But it needs to go further so that there's more attention to how the changes take place in all of the regulatory language that really governs how the state operates. And that's the next challenge. And the second thing for y'all to know is you have a lot to work with. That's the first thing. The second thing is every question you ask has an answer. You know, there's a way you can make this work for yourselves, but you need to ask for help. Don't assume that because when you look at it, it seems confusing and complicated that it can't be done. It's actually much simpler than it looks, but you need to ask for help from people like me, but other people, if you know, who know how to do this and know how to rewrite the things you need to rewrite. So in terms of hiring hopeful and helpful people and helping people be hopeful and helpful, this is not the total answer, but it's very important. Don't rely simply on training people once and then they're hopeful and helpful. Hope and help are things that you have to build in as important cultures of your organization. And the best way that I found to help people understand what that looks like is to think about things like customer service training. And think about how organizations that are not even in the human service business, a retail store, a restaurant, a hotel chain, help all of their employees be in the customer service business. I mean, I used to travel a lot back in the day, and I would check into some random hotel in the middle of nowhere in the middle of the night. And some person who's working as a desk clerk on the night shift in a little town somewhere would be really super nice to me. Was that because he was like the amazing, nice person who wanted to work nights? No, it's because everything about that job was organized with the idea that being nice to the customer was a priority. It was hardwired into everything they did. And the problem with us in behavioral health is the thing we hardwire is generating billable units. It's not about welcoming and hope. It's not that billable units aren't important, but if you don't know how to build values first into the way your organization functions so that the people you're hiring, whoever they are inspired by being part of your team and feel like everything is about rewarding people for being welcoming and inspiring hope. And that's the way they're trained. They learn the scripts, they learn the things to say, they learn the things to write, and that all of our instructions are lined up to prioritize that. Your productivity and revenue will take care of itself.
I mean, that definitely bears true in Westchester. So where we started and where we ended up, like we were doing really well plotting forward, but one would think that the pandemic would have put everything on hold. A lot of committees suspended operations. We went as a co-occurring system of care committee from meeting every other month to meeting monthly. The hope and inspiration and the motivation that we brought to the table around meeting people's needs in the most complicated times you could imagine with telehealth and access, that's when we really gained even more momentum. My funding came during the pandemic because people started recognizing how closely aligned these two topics were, but the people who were entering the field were not really being supported the way they could. They were burning out really quickly. They were not feeling particularly hopeful in the field that they chose because people were dying and people were not doing well. And when you introduce a model with a level of enthusiasm that people can really sink their teeth into, and they're learning and they're rediscovering, you know, if you're somebody who's been in the field, you're rediscovering why you entered the field. And if you're young and kind of bright-eyed and bushy-tailed, you're thinking about what might have been missing in your educational experience. So in New York State, we're looking at how we license and credential some of our professionals, how we can embed co-occurring competency like right out of the gate as we're moving forward. But none of that would happen if we weren't already moving the system forward. And I know given the framework of this group, and I know there's a lot of people that are participating, but for those who are family members, for those who are trying to figure out like where they fit into the equation, like not everybody's going to be me. I'm a lawyer by training. I thrive on this kind of energy, but just to be able to be at the table, to hold people accountable, to put a face to the conversation and say, you're doing this because there are other people like my person out there. And every time you move a step forward, you're changing the trajectory of somebody's life. That's huge. Somebody asked, I saw there was a question about the jail system.
I was just going to ask you.
I mean, there's a lot of time and attention being put on medication for opioid use disorder, which only gets you so far. And particularly in Black and brown communities that have been over medicated by standard of course, introducing integrated care, being able to deliver those kind of services in the jail, and with bail reform in New York State, being able to navigate people to integrated services is game changing. And so this requires sort of like the whole lift. Like a lot of people privatize the mental health services that take place in the jail systems. Well, those providers need to know what to do. Who's pushing into the jail system? How do you connect people to resources, not just mental health and substance use, but housing and vocational skills? Like, how do you build the safety net around the person? I'm very fortunate in Westchester that our Department of Community Mental Health jail person is one of my co-chairs of the committee. So we're very embedded in the jail system.
And just so those who are participating in this webinar, FAN is going to get involved with the Washtenaw County Sheriff Office to do exactly what Stephanie just said. And there are other community-based organizations who are already doing it, but everything FAN does, peer recovery coaching, all of our services, transportation.
It's going to talk about peers. So we're also looking in New York State at an integrated certification for peers so that there's consistency, because right now between our two siloed agencies, some the things are reimbursable, some you have to pay for your certificate. There's better parts of each one, but neither really looks towards the other as far as a training opportunity. Some of our agencies require their peers to be duly certified, and some of that language is not really consistent. So we're also looking at building kind of those skills together.
Yeah, we've got additional questions here. Do you recommend any training programs for practicing clinicians?
I'm writing the answer right now.
Awesome, Dr. Minkoff. And
what I'm saying is Michigan has excellent training opportunities for co-occurring. I mean, it really does. It's not hard for people to get good training. What's hard is learning to actually do something differently by virtue of the training. So just think about it. If I send you to an hour training on being welcoming, you're going to say, oh, that's interesting. And, if your organization doesn't support welcoming, you're going to be unwelcoming a week later. Doesn't matter what training you went to. I can teach you how to learn what the stages of change are in an hour. But practicing how to use them regularly and identifying stage matched interventions, that takes practice. So what we tell folks is if you want, there's a bunch of fairly simple, straightforward things for people to learn to do, but they're not going to learn them without practice. This is not like you just go to a lecture and then you're trained. You have to practice. And so there's a lot of expertise in Michigan that's out there. What isn't lined up is a clear set of instructions that says, for example, you're a mental health practitioner. You need to be welcoming people with co-occurring. You can't be sending them away. You have to screen and identify and document the issues. Your supervisor is going to look at you to see if you did that. Here's the tools. You can use them, but you have to actually write stuff down. You have to identify their stage of change. You have to do a stage matched intervention. Okay. And we've taught you what that is. Now we're going to help you actually learn to do it and do it consistently so you get better at it over time. It's what we do here in this program.
Right, for New York State, we're actually looking at quality improvement projects around co-occurring disorders. We have sort of research teams and you know, we have our New York State Psychiatric Institute and the Center for Practice Innovations. We're leaning on them to provide free resources to really build that stage-matched capacity to kind of help the agencies and the organizations move along. And so those are critical pieces of the work. And Jermaine, again, you're asking about the separation. The separation definitely is a barrier, because I mean, even in some of our hospital systems, they have like the mental health unit and the substance use unit, and you're getting like separate kind of paradigms in each space. We work consistently to try to bring those together and to be able to meet the individual. We have peers on the opioid settlement board who still to this day share stories of telling somebody with suicidal ideation, if they're showing at a substance use door, to not talk about that. And if they're showing up at a mental health door, telling them not to talk about their substance use. So these are real systemic challenges. There are still some places where you have to write what the primary diagnosis is, and it needs to match the agency and their license. Like that, we actually wrote a paper on the current barriers in New York State to successfully addressing co-occurring. So those are the kind of things like you need some people willing to get into the weeds on some of that stuff to really be able to parse it out. So the legislature, who thinks, you know, we have an integrated services license in New York State. It's a physical plant license. It has nothing to do with how we deliver any services. And so people think that they've done things that check the box and make it work, but it actually doesn't. And so you need to kind of have some people exploring what's working, what's not working, and what the legislators think they put into place and what that means in practice.
Stephanie, what was the question that you just answered? Jermaine is listening. And
So he was specifically asking about the physical separation of units within like a hospital system, for example. And so in New York State, one of the things that our two agencies are very excited and quite proud of is that they created an integrated RFP for crisis stabilization. Now, that sounds really good because now it's a 23-hour and 59-minute opportunity to meet with a person, triage them, keep them out of the ER, and really assess them for both. So the frustration, the challenge, and the burnout is going to come if there aren't community-based resources to navigate people to that are co-occurring competent, because now you've identified individuals with co-occurring, but where do they go next? So it requires like you bite off the pieces and you're celebrating, as Ken always likes to celebrate the successes, but you always have to look at what the next goal is, what the next step is. Great, we have integrated crisis stabilization. How does that support the agencies that want to do integrated work? And what do we do to support them, not just in saying they're co-occurring competent, but what kind of supervision? How do they get compensated for the time they spend practicing? Because, you know,
Right.
some things require work. It's, you know, we do clinical consultation on Encompass. It's unfunded. People get grants to cover it. Like the state should be paying. That's what opioid settlement dollars should be used to bolster.
And let me just add, because somebody made a comment about the insurance companies getting in the way. The insurance companies actually would benefit if they're managing populations from being able to deliver integrated services better. They just don't know how to go about it.
that's right.
So that's why I'm saying, and in Michigan, you forget the insurance companies are, especially the ones that manage Medicaid, they're hired by the state. So you can include in their contracts what you want them to be doing as part of their management.
But in New York, in New York,
helping them to deliver more integrated services, health and behavioral health integration, mental health and substance integration, inside all the services they're purchasing would be in their interest as well as in the state's interest.
right, because in
But, you
we're
know,
having them pay for things that don't work. We're having them pay for
just
stuff.
telling them they're managing one pot of money doesn't deliver integrated services. It just means they manage one pot of money and that's it. But they need to be accountable that if they're spending money on mental health, it has to be for mental health co-occurring. And if they're spending money on a substance program, it's for substance co-occurring. And if they're working with a primary health center, they're encouraging integrated screening and integrated practice in the primary care setting. Those are all things that can be done and developed within the available dollars that they have and will produce better outcomes for them. So again, it's possible to do, but everybody has to be like, yes, this can happen, and folks know how to do it. And if we don't know how, let's get help.
Wait, I think this, U of M hospital admitted our son for mental health, suicidal with meth usage, but they did not follow up with a follow-up program for him. Again, they do not follow up on the program they suggested. So that's more of a comment, but,
Well, no, but is that, I mean, so I'm not sure what your son's insurance was and how the hospital is oversight. Okay. So again, you know, there are licensing expectations for hospitals in the state, and there's capacity for reviewing psych unit quality. And Michigan is very persnickety about making everybody meet their targets for performance. The issue is, do they have the right targets for co-occurring performance that they're making everybody meet?
it's Medicaid insurance, Dr. Minkoff.
And then there's a Medicaid payer plan that is likely to be paying for that care. And that again is, and I've lived in a managed care environment where the managed care company actually cared about stuff like this. And if we didn't do it well, they were all over us when I was in a hospital. So I know that when you're saying like that, they did that. That's a quality issue that needs to be embedded in the hospital's quality system and the regulatory quality system and the funding quality system. And there are plenty of places where you can say that should not ever happen. Okay, but if it's just like, oh, co-occurring, yeah, well, we're a mental health hospital. We don't do that, and he's not suicidal, and drugs aren't our problem. Then stuff like that happens, and nobody thinks it's a quality issue. It's just bad luck.
We are up against the end right now, you guys, and I want to stay true to trying to wrap this up. Michelle mentioned the importance also up here in the chat, the importance of including trauma-informed as a part of co-occurring, and I know
absolutely
you are both huge advocates for that. And well, we could talk for another hour, but we can't. And I want to thank both of you for taking the time to share your expertise. Dr. Minkoff, your clinical expertise and process improvement expertise, and Stephanie, you're awesome. I concur with everything Dr. Minkoff said. Your energy is contagious, and thank you for all your hard work. And Dr. Minkoff, it's interesting. You know, you said sometimes you can learn from, if you're a healthcare company, maybe you can learn about customer service from other things. The healthcare organization that I used to own with business partners, and I'm going to plug an institution here in our community, Zingerman's Deli, that the two of you are going to learn about, because I'm going to get you gift certificates to Zingerman's Deli. They're known internationally.
Do they ship?
They ship. You're going to go
right.
online. I'm going to send you and Stephanie a gift certificate. They are excellent at customer service. So we hired them. They have an international reputation. And by the way, the owner, Ari, hires a lot of people in recovery, which is another reason why I wanted to send you Zingerman's gift certificates. But we hired them to help our folks who are dealing with patients be better on the phone with them. And so they did a great job. And so that's just using a Minkoff idea. You know, we did that and hired a deli to learn from them.
Well, the thing that's weird, though, is we're in a business where what we're doing is much more important. No Zingerman's than selling salami. But we don't normally do that. We have people whose lives depend on our ability to welcome and engage and inspire them. And yet that's an afterthought.
I agree 100%.
That's tragic.
Yeah.
And it's not necessary.
So look, thank you both.
Have a great evening. I'm
Yeah,
gonna
you
go.
guys
Now you made
take
me
care.
hungry.
Thank
and I'm
you
gonna
so
go
much.
eat dinner, because
Okay.
here it's before dinner, not after dinner. So
Yep, we'll see you. Thank you.
take
Bye-bye.
care.